Hey everybody, this is Tracy Brackin, family nurse practitioner and doctor of nursing practice student submitting the audiovisual presentation for the discussion board moderation for Advanced Practice Cognate 1. This week we're going to be discussing mind over bladder, skills for management of asymptomatic bacteriuria. You can read over the learning objectives, but essentially after the presentation and reading the materials that are provided, you're going to be able to have more confidence regarding the interpretation of the evidence-based practice provided in the treatment of asymptomatic bacteriuria, and look at a urinalysis and be able to differentiate between asymptomatic bacteriuria and a true urinary tract infection. You'll also be able to summarize those resources that are available that have been provided to you, and also be able to find more if necessary for further research if you're interested. And you can use these resources to develop a protocol of your own in your own practice setting if you find a knowledge deficit, or if you want to educate staff or other clinicians or patients or family members regarding the delineation or risk stratification with diagnosing a patient with asymptomatic bacteriuria versus a true urinary tract infection. People have actually been assessing urine for a very long time, and we would think about Hippocrates as the very first urologist or uroscopist, according to Armstrong in 2007. Hippocrates actually had a chart regarding the different characteristics of urine and how they corresponded to different disease processes. And in the 17th century, people were tasting urine to diagnose different diseases, specifically diabetes. If you look at the etymology of the words diabetes insipidus and diabetes mellitus, they actually correspond to how they taste. Insipidus truly means you can't taste it, and mellitus actually means sweet tasting or honey tasting. This slide reviews the different elements of a urinalysis. We'll be talking about those that are specific to the diagnosis of asymptomatic bacteriuria versus a urinary tract infection right now. So we're going to look specifically at the pH, which is how acidic or how alkaline the urine is. If you see a lower pH, which means a more acidic urine, you would be considering that the patient may have increased protein intake, or they may have supplements that acidify their urine, such as vitamin C tablets or cranberry juice or cranberry tablets. If the patient has a higher pH or a more alkaline urine, you would consider that the patient may have a urinary tract infection related to urea splitting bacteria, or they may have a vegetarian diet. The next element that we're going to look at regarding our diagnosis would be red blood cells, which is indicative of hematuria, which is almost always pathologic. That could be indicative of stones, inflammation, infection, trauma, or tumor. One would consider further diagnostics are needed if a patient presents with painless hematuria, and we would typically think of bladder cancer or bladder tumor. Leukocytes are truly pyuria or pus in the urine caused by a urinary tract infection typically. And the bacteria, of course, as in the urine, it will typically say no bacteria detected or none, or moderate, or often too numerous to count. But you don't know what specific bacteria is involved until you obtain the culture. But usually a true urinary tract infection is categorized by at least, or actually 100,000 colony-forming units of bacteria. Oftentimes, if you see less than that, verbiage will be included that will say it's related to probable contaminants in the urine sample. And we'll talk later on about the difficulties with getting true urine samples from elder persons. And if we look at nitrites, of course, the nitrites are typically positive if you have a gram-negative bacteria present in the urine. So what is bacteriuria? Actually, the Scottish Intercollegiate Guidelines Network says that it's not a disease. It's actually bacteria in the urine, and it's more common than originally thought. In 2011, Davy, Phillips, and McMurdo published an article saying that up to 40% of men and 50% of women in long-term care facilities have bacteria in their urine. Why is this? Well, it's actually not very well understood. It may be that the colonization of the bacteria in the bladder is actually a less harmful or less virulent strain. But our goal as clinicians is to differentiate once we determine that the patient has bacteria in their urine, do they have symptoms or do they not? Actually, we can't rely solely on a dipstick urine or even a urinalysis anymore. It's very difficult in our elder persons. Specifically, well, they're more at risk for developing a urinary tract infection. Why? They have multiple comorbidities, multiple disease processes that may predispose them to having a urinary tract infection. They're often dehydrated or fluid volume depleted, sometimes have poor hygiene, and it's very difficult for them to wipe appropriately. And they may be experiencing atrophic vaginitis, which happens in postmenopausal women. That's actually a lack of estrogen to the vaginal tissue. So instead of having red rugated vaginal tissues, you would see pink, smooth vaginal tissues. And that often accompanies pelvic muscle weakness, as well as a greater propensity to have a urinary tract infection. So I think the most important thing to take away from this entire study is when we're talking about symptomatic bacteriuria versus asymptomatic bacteriuria, well, what are the symptoms? We need to be thinking about that. Actually, the article that's provided for you by Andre Leduc did a wonderful job categorizing the different symptoms based upon whether the patient had an indwelling Foley catheter or not. They also highlighted some nonspecific symptomatology for urine characteristics. So if a patient does not have an indwelling Foley catheter, we would consider symptoms being new or worsened dysuria, fever, typically 1.5 degrees Fahrenheit over the baseline, and often elder persons have a lower baseline body temperature. We would also think about frequency or urgency, flank pain or costovertebral angle tenderness, suprapubic tenderness, and a change in the urine character or a change in the patient's functional status. For those that have indwelling Foley catheters, which actually makes it extremely difficult, we would think about fever, flank pain, suprapubic tenderness, a change in the patient's urine characteristics and functional status. And nonspecific symptoms include a foul odor. In my own practice, or things I see every day, I would also want to add a couple things. I note that an increased risk in, or actually increased falls in patients really gets my mind to thinking I should probably evaluate this person for a urinary tract infection, especially if they have other symptoms that I previously listed. As well as for the indwelling Foley catheter patients, I often note that catheter obstruction is one of the first things that will let me know about an impending urinary tract infection. So once we talk about the symptoms, we say bacteriuria with symptoms. Of course, there's no issue here. We need to treat this. However, we need to do appropriate antibiotic selection. So that often means we need to wait on the culture. And if we don't wait on the culture, we certainly need to review the culture when it's available and de-escalate our antibiotics if at all possible. Gazzari did research recently that showed 46% of urine samples taken from elderly persons are contaminated. And Nazarko said that 14% of patients require a second antibiotic in 28 days or within a 28-day period. And I can't help but wonder, did these clinicians review the culture, or did they obtain a culture and de-escalate their antibiotics as they saw fit, or was there something truly physiologically wrong with these patients and that required a different type of antibiotic therapy? So we've covered the fact that we should treat if the patient is symptomatic. That makes good sense. But if the patient is asymptomatic, meaning they don't have any of these symptoms that we listed, we actually need to do a thorough assessment and ensure that that's the case. We need to have our hands on the patients. Again, we can no longer treat a urinary tract infection, quote unquote, based upon a urinalysis or a dipstick. We have to clinically assess the patient and use our judgment, because now we end up putting the patient at risk for developing adverse drug reactions related to antibiotic therapy, and if that's not needed, then that's not actually good practice. So we need to think about the risks versus benefits when we put somebody on antibiotic therapy. What do we think about? The patient could have adverse drug reactions, they could have allergies, they could get Clostridium difficile colitis, or pseudomembranous colitis, or antibiotic-associated diarrhea. They could also have increased bacterial resistance or multi-drug resistant organisms. And of course, cost happens to be an issue, especially when we consider a bacteria that is extended spectrum beta lactamase producers, and maybe the only antibiotic that works is an intravenous carbapenem, and then you consider that you're spending thousands of dollars in treatment for this urinary tract infection. So Chowdhury in 2012 says that it's not only not beneficial to treat a patient with asymptomatic bacteriuria, but indeed it may be harmful. I often use a study that I bring up in my place of practice simply because the sample size reflects the number of patients that are in the skilled facility that I'm at typically. This study was done by Rotjanapan in 2011, and it involves 172 residents. Actually, 172 residents got a urinalysis. All of them were abnormal. So they reviewed each patient for symptoms that I explained above, and actually 26 of those patients met criteria for treatment, so they were placed on antibiotics. That left 146 patients that were not candidates for antibiotic therapy based upon their symptoms. So they essentially split that group in half. So 76 of these people were not treated. They did not have antibiotic therapy. And 70 of these patients were treated. They were prescribed antibiotics. So of the 76 that were not treated, nothing bad happened up to 3 months after the study started. Nobody got septic. Nobody went to the hospital. Nobody died. There were no bad outcomes. However, if you look at the 70 people that were treated, of those treated, 12% got C. diff within 3 weeks. And in 6 weeks, 60% of those patients had a regrowth of either the same bacteria or a new bacteria. So we really have to consider our evidence-based practice, and is it appropriate to treat these patients. So we look at different resources that we have available to determine evidence-based practice. And the first website I go to typically is Choosing Wisely website, which is established by the American Board of Internal Medicine. You can do a search and it will populate different societies' positions on evidence-based practice with whatever your search field is. When we type in asymptomatic bacteriuria, several things populate. Actually, the American Urology Association says we don't need to prescribe antibiotics unless there's a sign or symptom of a urinary tract infection. The American Geriatric Society says no antibiotics are needed unless specific symptoms are present. And then, of course, there are other resources available on the web, which include the Society for Hospital Epidemiology. They have a long-term care subcommittee that says antibiotics are not indicated for long-term care residents without symptoms of a UTI. And the Infectious Disease Society of America says antibiotics are not recommended for patients without symptoms in the diabetic female, the elderly, the institutionalized, indwelling Foley catheter. However, we do need to consider screening and treatment for these patients who are expecting to have surgery where mucosal bleeding is possible. Now, we're talking about this in elder persons, but I want to say that there's different literature that discusses the treatment of asymptomatic bacteriuria in the pregnant female. So, of course, consider that when we're talking about this. So, with the information that we have, actually is quite statistically significant. It alters my practice, and I hope that you will think about it as well. If we have a patient that presents this way with no symptoms, however, a urinalysis is showing bacteria in their urine, what do we know? We feel pretty strongly that if we don't treat this patient, nothing bad will happen. However, if we give them antibiotic therapy, could we indeed do harm? And some of the studies that we reviewed, the literature that I posted, indeed says yes, there's a chance that that could happen. This is one of my favorite sayings, and one of the things I tend to do very frequently. I find that I'm justifying a lot about why I don't want to put someone on antibiotics, or I have to battle and explain myself regarding why we don't want to do a urinalysis. It's not that it's not a good request, it just requires education for the family. Mama has a UTI. Hear it all the time. So we look at different symptoms that mama or dad may manifest that would cause a family member to want to say that. Many say mom doesn't present like normal people do when she has a urinary tract infection. She gets very confused. Well, what else can cause confusion? We would have progression of the dementia process. There could also be toxic or metabolic causes. I had a patient very recently with this situation, and I talked about it with the patient's son. The patient wasn't experiencing any other signs or symptoms of a urinary tract infection, so I told him we would do further labs to evaluate, and of course we did a CBC, CMP. We actually took an ammonia level, and when we got that result, the patient's ammonia level was markedly elevated. So of course, once we administered lactulose, the patient's encephalopathy resolved back to her baseline dementia status. So often we can consider confusion being a manifestation of a different disease process other than a urinary tract infection. Pyuria, we talked about this previously, especially in most postmenopausal women who have atrophic vaginitis. Sometimes this burns upon urination. Bacteriuria, we've certainly been talking about that and how it's possible to have bacteriuria without having a true urinary tract infection. And we know that nausea, vomiting can have other sources or other causes, like a viral gastroenteritis or an obstruction ileus. Urine smell or appearance. We know that different foods and fluids can change the characteristics of urine. Very recently, I had a nurse tell me about several different patients, all in the same day, that had foul-smelling urine. So I was asking for further information, paint me a better clinical picture, tell me about their vital signs, let's talk about symptoms to see if we need to screen these patients. And in fact, as I was waiting for this information and looking at charts, I was watching different food trays go by, and I noticed that on the menu or on some of their plates, asparagus was served for lunch. So you can't help but wonder, is that why several people's urine smelled different today? Clinical deterioration could certainly be related to further disease progression, be it dementia or any other disease process. And fever, we know, could be indicative of other infections. It doesn't have to be the urinary tract. It could certainly be pneumonia or a cellulitis or an intra-abdominal pathology. The patient may indeed be experiencing some C. diff colitis related to some antibiotics you prescribed 3 weeks ago for their urinary tract infection. So in this instance, patient has encephalopathy or any of these other symptoms. A urinalysis to me is only valuable or beneficial if it's negative. Then we can rule out a urinary tract infection. When we look at treatment options, we would certainly consider deliberate antibiotic selection if the patient has true urinary tract infection and you're considering antibiotic therapy. Again, we need to review the culture and de-escalate or use the best antibiotic possible. And then the last three are certainly related to urinary tract infection prevention. Of course, bathroom hygiene, which we tend to take for granted, but we certainly need to educate our patients regarding wiping from front to back. However, this is sometimes difficult for our elder persons. We need to encourage the patient to acidify their urine. How do we do that? Well, we can do that with vitamin C tablets, cranberry juice, cranberry pills. Actually, Sabata in 1994 did some studies that show that 200 milliliters of cranberry juice twice a day inhibits bacteria from adhering to the bladder wall. So this is when the cranberry craze kind of started. Certainly with patients, it's very difficult to encourage fluids. We would consider that elder persons especially have been independent most of their life, and now they're reaching the end of their life and they're becoming more dependent on other people. It would behoove them not to drink more fluids, because why? That means they need to go to the bathroom, and then what do they have to do? They have to call for help to get to the bathroom. So that I hear that very frequently. I don't drink because I don't want to ask for help to go to the bathroom. And so another thing that's actually not incorporated in the slide, but is certainly extremely important, for these patients, we do need to have a regular toileting program. That would give them more encouragement to drink their fluids and help mobilize them a little better. So I want to thank you for listening to our audio-visual presentation regarding asymptomatic bacteriuria. So review the articles that we've posted. And participate in the discussion board. I'm really interested to see what you all think about the evidence that we provided and the treatment of asymptomatic bacteriuria versus urinary tract infection. Also, I know that we all have different practices and we all come from different backgrounds. So I'm interested to know if you have faced a similar situation where you've reviewed the evidence-based practice and it's caused you to change your practice to improve clinical outcomes, and you find that you're having to do lots of education with other providers and clinicians and patients and families. And lastly, I would ask you and appreciate it if you divide and conquer and talk to other providers and clinicians if you happen to see asymptomatic bacteriuria in your area, and maybe discuss the importance of being good stewards of our antibiotics. So education will certainly help our providers, and we'll be able to talk with our patients and families about treatment options. They don't necessarily have to include antibiotics if we know that the patient has bacteria in their urine. Thank you, and I hope you have a great week.